audio is not. Sir, audio.
Yeah.
Yes, sir. Now it is heard. Yes, sir.
Yeah. Good afternoon to all the participants over here. I am indeed privileged to welcome Dr. Muralidhar Joshi and all other participants, not only from AVMC, from other institutions as well, for this 35th episode of the Future Front, Forefront of Future Frontiers. And I take the opportunity to, on behalf of our management, on behalf of our Honorable Chancellor, Vice Chancellor, then the Board of Management at large. Now, I just for the information of the people who are new to this platform of FFF webinars, which has become very popular for the past almost 8 months. You know, it was established during the peak of the COVID period. And in these 35, 36 weeks, it has earned credibility, and the platform has been shared by big guns in their respective fields. Eminent scholars, eminent academicians, eminent researchers, eminent teachers, eminent scientists have shared this platform and shared their thoughts, knowledge with all the benefit of all the medical fraternity at large. Now we have crossed over 6,000 over the database of the participants in on this platform, and each time now we have addressed various issues. Of course, many of the webinars were during the time of COVID, the focused area of COVID on now on the cancer, then on education. So many issues have been addressed on this platform, and now, being an anesthetist, we were till last session, we were addressing the issues related to the malignancy. And in fact, when I was talking to Dr. Muralidhar Joshi, I requested him also to include the pain alleviation in malignancy as well, to suit to the current series of cancer cure or cancer treatment. And now, this much of this preamble for this webinar, I'll say in one word, it has become an institutional character, and it will go on continuously hereafter. And now, this subject of pain, one thing is pain alleviation. When it happened on 1846, October 16th, that was the day when the William Thomas Green Morton, he made a public demonstration of anesthesia. Of course, it was a public demonstration of alleviation of pain, wherein the surgery or the operation was agony before, then it became a unique, different experience, painless. And that we can say the modern history of alleviation of the pain. Prior to that, many crude methods like hitting it on the head and all. We're not going to those details. See, the modern day alleviation of pain is it dates back to that date, almost 170 more than 170 years now. Now, pain alleviation has been a greatest gift to the mankind. Because one thing is, we all know pain is a God's law, and you can't eliminate or you can't overcome. You can only circumvent that law. That's what we pain therapists or anesthesiologists they do. You circumvent the God's law for a particular period of time, irrespective of the cause of pain or type of pain. So whatever you alleviate, that you will be circumventing or you're configuring a barrier around that. That's what is meant by circumventing. Malakshmi, can you make me host? I have to have a. With this, some thoughts of myself being an anesthesiologist. Anesthesiologists are involved in the alleviation of pain in many of the hospitals, not only acute pain management, even in the chronic pain management also. Acute management, main component of that will be the post-operative pain management. And nowadays, the pain before, during, after surgery, almost you can say totally controlled. Yeah. Is it visible? Is the slide visible?
Yes, sir. Visual, sir.
Yeah.
Sir. Yes, sir.
Hey. Okay. Now it is my pleasant duty to introduce my colleague, Dr. Muralidhar Joshi, and he is presently the head of the Department of Anaesthesia Pain Medicine, and is the director of pain medicine in Virinchi Hospital, Hyderabad. And I know Murali for the past almost more than 2 or 3 decades. Ever since he was a student, he has been a very sincere guy, sincere person. But now, as a student, as a teacher, now, in fact, I'm very proud to say that he has groomed 3 of my students, especially in the pain management. The activity of the pain alleviation activity he is carrying out in the past 2 decades, in more than 2 decades, I think, in Hyderabad, has really brought the pain management on the international map, international map, or the anesthesia fraternity or pain management fraternity has been brought on the international map of the pain as well as anesthesia. The sort I can, in one sentence, I can tell you, there are many credentials which he has earned by his hard work. And I already said, he is about a special interest as a pain management, pain education, and pain intervention, pain management. And he has nearing 20,000 acute pain interventions to his credit, and he has nearing 10,000 chronic pain interventions. And one thing, the pain is still, in spite of being such an old thing, is still an infancy in India, in the sense not all the hospitals, not all the cities have pain therapists, their clinics, their shops, or nothing of that kind. Only in some cities you are hearing that, to metros, like that. It's still a lot of virgin area in that pain alleviation practice. And yeah, more than a quarter century experience, his publications, books, and his outstanding achievements, with being the first enrolled application in the world on the intervention pain management. That's a wonderful thing that brought our country on the international map. And he's the first to start a fellowship in pain management in India. And by virtue, he was the member of the World Federation of Society of Anaesthesiologists, the executive committee member. And he certainly made use of it, and pain fellowship, he brought it to India, the overseas fellows. And yes, he's the first author of a textbook of pain management in India, and the first to start e-learning of pain management in India. I remember even, he goes on from different places. By this time, he would have come if COVID were not to be here. He comes with his team and hands-on training impart a workshop on pain. That he did in my earlier 2 institutions. So now, hopefully, in the time to come, certainly I will not miss an opportunity to invite him for the benefit of our students. And he had various prestigious positions in the national organizations. He's a past president of Indian Society of, an immediate past president of Indian Society of Anaesthesiologists. All of you know, it is the membership is exceeding more than 35,000-40,000 now. And he is the executive committee member of the World Federation of Society till 2020. He was a member of the World Federation of Society of Anesthesia, Safe Anesthesia and Quality Practice Committee. He is a member of the Pain Relief Committee of the WFSA. They are all these very important positions. That's why I said in one sentence, he has brought the Indian system, Indian doctors into the world map of pain management, world map of anesthesia. And he was a sub-editor for the anesthesia tutorial of the WFSA, that was a regular feature. Then he's presently he was a past secretary of Indian Society of Study of Pain. And now he was the treasurer of the Indian Society of Anaesthesiologists prior to he becoming the president. And he is, of course, a reviewer of many national and international journals. And his publications, his presentations have been innumerable. It already we are running behind the schedule. In one sentence, I'll finish off. He has so many orations, so many publications, and so many presentations in various national and international conferences. And indeed, we are very much fortunate to have him here to share his thoughts and experience on this important topic of the pain management and overview. Over to you, Dr. Mahalakshmi.
Sir, there are only few housekeeping announcements before we proceed. One is recorded for academic purposes and posterior use, and we'd share the link. Also visit YouTube channel and see the recordings of all this webinar as possible. So now, without much ado, we will have Dr. Muralidhar Joshi. Over to you, Dr. Joshi. You can,
thank you, madam. Thank you. I hope I'm audible. Am I audible?
Yeah, you are audible, Murali.
Yeah, thank you, sir. Thanks, sir. I think I should thank Dean Professor Kotru, sir. I never had this much a big introduction anytime in my life. Let me thank you that not even during my marriage also. Forget about anything else. So, like suddenly I started discovering myself, look, I did do all these things, but it was all blessing from all the seniors like you people, sir. You made us to this particular stage, and your intensity at your age and phase, still what you're working, that is motivating us to take up this task. And thank you, Dr. Mahalakshmi. It's a fantastic thing what you've been helping me out. And my apologies to all the audience. You may not be see my video because I just had some problem with the Cisco. Not for this every meeting I used to have. Then I realized the difficulty was that the hospital network is not allowing this one. And right now I'm using our own mobile network and all those things. And please bear with me. Slides you can see. Probably cannot see me. Probably is more of virtual. The ghost who walks more like a phantom. Please accept my sincere apologies. Once again, thank you, Kotru sir, for inviting me for this great event. And of course, I'm happy to be part of this forefront of future frontiers. And it's a great honor for me. Thank you so much, sir. I think we'll get on to slides. Madam, please can you help me in moving the slides? Thank you so much, madam, once again.
Also, there's some issue going on with the Cisco. So you can start I will get the slides. Start the talks. Hello?
Yes, madam. Slides, madam. Slides.
You can see.
Not started, madam. Not started.
Started. There is a problem. And get I can slide capture.
Yeah, madam. I'm just waiting for slides. Waiting for slides.
Mahalakshmi, slides are not moving.
Second slide.
Today, Muhurtam is not good, I think. You never have.
Sir, every time is good time, sir.
One thing, Murali, believe me, our 35, we have never been a problem. So flawless.
Sir, learning experience, sir. That's what you taught us. Every the challenge comes with an opportunity to learn more, sir. That's what I have learned from you. So I take every challenge as an opportunity to learn.
That's what, positive.
That's the way to move forward in life, sir. But of
No,
course, when preparing for the slides,
positive attitude in negative situation.
It's very important, sir, because we should not become slave to technology, sir. Most important. Well, but having said that, okay, as Madam is trying for this one, let's continue the discussion, sir. Why we are discussing
No, it will come. One second.
Yes, sir.
No, I was just telling, and pain itself is an positive attitude in negative situations is pain.
So that gives an opportunity for us to work to improve ourselves. That's the possibility. Sir, we talk of, in fact, today's discussion is overview of pain management. Of course, I'm starting my lecture already, sir. Don't worry about that one. Slides and all. Let it come when it is going to come. I'm comfortable this way also. If somebody's coming audio. So, actually, as rightly pointed out, from the or historical perspective point of view, if we are discussing about, say, for example, part of what is pain management.
Murali, 1 second.
Sure.
Murali, hold on for a minute. Mahalakshmi, can I have to mute everybody? All the participants kindly bear, in a few minutes, it will be whole thing will be resolved. Okay. Murali.
Sir.
Just 2 minutes you bear,
I'm comfortable, sir.
Yeah, I call Mahalakshmi only to hear, and because mine is going on flawlessly, I can do that. Safe. Mahalakshmi is coming. Vishnu is not working. Come here. Where is that composition that Sandhya? Not yet circulated. Yes, sir. I correct that. You tell him, where is the committee has been not constituted? How can you send a meeting notice? Hey, what give me now? Why are you taking so much time? Morning only in such a garbad I gave. The OT committee of the constituted as under committee, Madhavan, James RMO. Okay. The duty and responsibilities of the OT committee. The committee shall meet once a month on any convenient date as decided by the chairman between 2 and 4 p.m. Malakhi Bandra? Okay. Hello? Yes. Okay.
मैंने क्या क्या बाथरूम में आज हुई क्यों क्या हुआ मैं पहले हाथ धो के करना था ना आज हुई मैं आप धो के शिशु किए ना हाँ मैं हुई पे हाँ उसने इन्फेक्टेड रहता है तुमने वही किया ना नहीं किया हुई हाथ में अच्छे से धोए हाँ स्टील नल नहीं छुई तुम्हारा मैंने ये पेट्रोल मैं कुछ नहीं कर बाहर का ये दूसरे लोगों के घर में अक्षय का काम जाते चली जा रहे सब लोग सभी तरफ जाते हैं तुम्हारे अच्छे इंडिविजुअल दीदी को क्योंकि वो लोग सब नॉर्मल हो गए हम लोग नहीं हम लोग नॉर्मल हो नहीं सकते वो लोग भी नॉर्मल हम उधर दूसरी जगह का नहीं देखते वहां तो ये नहीं देख रहे वो लोग कौन कौन मास्क पहने यहाँ पे क्या नंदिनी की बेटी नॉर्मल हो गई यहाँ पे क्या मुरली की बेटी लोग नॉर्मल हो गए मास्क तो सभी को पहनना बेटी को कभी भी ये तो बात पहले रेगुलर जाती थी आ गया छोटा बच्चा आ गया लेकिन उससे बालियां मत दो फिर से चुप चुप चाटने मत चले जाओ
Sorry, Dr. Joshi, and sorry, audience, for this technical glitch. Suddenly, Cisco froze, so that is why I could not do anything. Now the slides are up for Dr. Joshi to talk. Oh. Hello?
Yeah, good afternoon, madam. Can you hear me?
Yeah.
Hello, madam. Good afternoon. Can you hear me?
Hello?
Madam, good afternoon. Can you hear me?
Yes, sir. We can hear you, sir. Please go ahead.
No, we do understand, madam. This is part of our life, actually. What?
Sorry, sir. Sorry.
No,
really sorry.
Nothing to feel sorry. The question here is every challenge comes an opportunity to get to know about people. That is the way you move forward, madam. Never, ever. We should feel annoyed about anything and all those things. Probably we learned something new today, and probably we are much more wiser than what we are today. Madam, thank you for helping me in moving the slides and all those things.
Yes, sir.
Pain is pain. Never mind about that one. Because it was after the Greek goddess point was named, the pain was coined. So, though it's defined as unpleasant sensory and emotional experience, so there's not a pleasant sensory and emotional. That can be something like a child kicking you, a small baby, maybe about a 2-month-old baby kicking you is pleasant. Is pleasant. But there's been same with somebody a rogue who kicks you is unpleasant. Sensory emotional experience associated with actual or potential damage or described in terms of damage. This difference came in 1974 from IASP, that is International Study of Pain, and of course subsequently recently they modified about a couple of years back. A little bit psychological aspect they added also. That's fine. Like headache, you cannot really demonstrate probably what kind of probably pain is there or what in injury and all, but it is part of the game. But the question here is, in simple words, what is pain? Patient says it hurts. He doesn't know. I have got maybe tummy pain. I got maybe some headache. I have got some shoulder pain or leg pain. He doesn't know. I think slide is moving automatically, madam. I think, yeah, thank you so much. So, you might be wondering why are we discussing this topic today. It's very important. When we got independence, the lifespan of 35 years. Now it is almost, we are going for Platinum Jubilee celebration of Indian independence. And the lifespan is around 70 years. That means double. Then what changed to increase the lifespan? But question here is, yes, there are a lot of factors which changed. Like we had when we got independence, We had our own problem with respect to malnutrition and of course talk of infectious disease, diarrheal disease and all. Then we had 5-year plan. Then we had the milk revolution, the green revolution. So many things happened. Probably seniors over here, they can recollect on all those things. Things changed probably by I should say 1990, the lifespan 35 became 47 years, that 57 years, now it is 70 years. So the relevance to today's session is reason being, you live for longer time, you have to pay a penalty to the Almighty or whatever the source you think and all, and that comes in part of degeneration, and that's what it is at this stage. Next slide, please. If you look at the prevalence of chronic pain across the global level and all that, before you go for chronic pain, just look at the prevalence of the other conditions. If you say cancer, it's about 0.4%. If you say coronary disease, it's 6%. If you say diabetes, 7%. If you talk of pain, 26%. So, but if you talk of cancer, now you talk of robotics, you talk of LINAC, you talk of maybe chemo, nanoparticles, and all those things. If you talk coronary disease, you say Douglas and stents, and probably one of the celebrities from cricket, you know about that one. He has 2 stents, and again he has some discomfort, goes almost. He's just 48-year-old. So these kind of things do happen. So not to get worried. And you talk of diabetes and all those things, you talk of insulin, inhaled insulin, or you talk of probably say probably mechanical pancreas and all those things. Am I disturbing somebody?
देखते हैं मंडे को देखते हैं तुम्हारा क्लास रहेगा.
Dr. Joshi, you can unmute yourself and speak. Yeah. Sorry. Hello? Hello?
Can you hear me?
Yes, sir. Please go ahead.
Yeah, no, I'm comfortable. I thought probably I was disturbing somebody else over
Can
there.
I move to the next slide, sir?
Yeah, no, 1 second. So,
that is
you can move, please move. I can understand the discomfort. Please go ahead. So different types of pain can be there. There could be superficial cutaneous pain. Depending on definition, what exactly pain? It could be superficial as good as a scratch on skin, deep non-visceral pain, something like low, dull backache. I think most of people who are above 40 years will be experiencing this one. Visceral pain because of some kind of, I should say, like gas discomfort or maybe malignancy, something like that. Referred pain, all of you know about that one, maybe like a heart attack which can come like a shoulder pain. Neuropathic pain, because now India is the sweetest country of 2020 because 25% of population are diabetic. So definitely we are going to have more neuropathic pain. Psychogenic and functional pain is one person sometimes when we don't diagnose what is the problem. Problem might be something else, maybe in the job or something like that. But if you look at the job and all those things, and if the pain is still there, that means probably the job might be the culprit. He's not happy about the job. Probably we'll have to change the job, or maybe we'll have to guide him about that one. It's difficult. Somebody who's a driver, we can't ask him to become a pilot next day or maybe something else other day. Next slide, please. I'm just hurrying through slides because I think we are running out of time. I think probably it's not fair on our part to hold on to people. Different types of pain. If you look at acute pain, for example, it's on a time bond. It depends on what kind of classification you have. Acute pain, little time and the severity, like something classical is surgical pain. Somebody has an abdominal incision and pain, as the wound heals, the pain disappears. That's fine. But cranial pain is something like same abdominal pain and surgery, and subsequently the person has long-term pain and wound heals, but the pain doesn't go. That becomes a chronic pain. So that's how we classify. But so there is about, we say, some people will say 8 weeks, or something like 12 weeks. It's about 8-12 weeks and all those to before you label any pain as chronic pain. Next slide, please. But can acute pain evolve into chronic pain? That's a theory what we keep on asking. Yes, it can happen. That's the reason why we are looking at these days extensive persistent cascade of neurochemical mediators triggered by, let's say, as simple as that. If somebody is bombarding with you with their own observation, their own thoughts and all, continuously, it definitely becomes a chronic pain. Maybe I would like to say, should call it as a headache, something like that. So persistent bombardment, the same problems, and all those things, the system goes inertia. Like you keep on clicking on the button on the computer, beyond a limit, the computer goes, it gets stuck. It's called as it gets stuck. It not get stuck. It's trying to reset itself. So same thing happens with the body also. So basically, when persistent firing keeps on happening, that stimulates A beta fibers which connect in the rex lamina of the spinal cord to sprout, grow and connect to A delta fibers. This then they progress long-term permanent neurological change that can lead to sensitization, allodynia, hyperalgesia. Because these are maybe wordings and all those things are different for the specialty, but for us it's the way it goes on. Basically, I say persistent bombardment of impulses leads to irreversible damage on the spinal cord or the brain that takes quite some time to heal. That's what we would like to say is persistent bombardment is one thing we should always try to. So that in that case, if you control acute pain comfortably, probably chronic pain may not come into picture. That's the whole idea what we want to drill in over here. Next slide, please. But why should we treat the chronic pain? Why can't we leave just like that? But yes, we have to treat because it's very important because it can lead to social family dysfunction. Somebody who is youngster now, for example, now say post-COVID, if I got joint pain, I can't go to work. If somebody, a 42 person says, just imagine two daughters or two sons maybe who are there, who are just studying and all those things. If the father doesn't go to work because of this pain, do you think it's possible for the family to survive? You have probably some savings and all those things, but beyond the limit, you run out of ideas and family gets into a problem. That's what we're talking about the growth of the country what we call it as GDP. That's what it is. It can be extensive, and if you really want to work on the investigation, costly, non-productive investigation, I might ask for MRI, I might PET CT, and all those things, and treatment. And if person doesn't want to go to work, kids cannot get to work because they're still studying, and probably his wife cannot go. Reason being because she's homemaker, or probably she was working earlier, she left the job again, getting a job. It's not so easy. So that leads the entire family to go through mental and physical suffering. Probably people who are bit sensitive what happened in the COVID time, they will understand what exactly it is. So many people have lost a job. It hurts. It hurts. That hurts. The word I would say is not physical suffering. It's mental or psychical suffering. It all depends on how you look at the world. Are you with the world? Or are you against the world? It happens like that. That leads to increased disability costs. Like I get admitted in hospital. I'm supposed to run the hospital, but I get admitted in hospital, and I won't run the hospital. I want to pay the salary. I won't do anything, and then find that leads to a disaster in the hospital. People keep on living. Increased healthcare costs, decreased immune response. Yes, your body is as good as you're fit. As long as you're fit, nobody can come to you. As long as your vehicle is running well, no problem. Regular servicing, periodical health insurance, all those are required. The day your vehicle starts creating problem, you get into problem. And death often by suicide, because when I can't handle the problem, a lot of people do this one. But actually, the problem was not that great. It's all my perception, and all those things. So this is where it comes, like when you go back to definition of pain, it's unpleasant sensory and emotional experience, associated with or without tissue damage. And in this context, the mental damage or physical damage is a different story. But psychological damage might make you feel that probably I exhausted all my resources. I think I don't have much option. So this is where we have to understand. There was one concept, maybe some of you might knowing in some one part of the statement. It's called DINC. DINC means a DINC. DINC. So DINC is double income, no children. I repeat, DINC is double income, no children. Husband software, wife software, no children. Husband takes loan, wife takes loan, buy apartment. Suddenly, COVID comes and they left high and dry. Now suddenly you have to pay all the EMI and all those things. That kills. So it all depends whether how much of life you have seen. It all depends on, and it's different. Of course, there could be sometimes distorted analysis for the different reasons and all, but facts remain the same. As long as you're able to handle your responsibilities, the pain is secondary. But if you cannot handle, pain becomes primary. So that's where you have to understand what is good for me, what's good for my family, and what is good for my nation. Because we are talking here about nation building. We're not talking about here a personal kind of benefit as such. Next slide, madam. But you can always stop me if you think time is running out, so that I can stop immediately whenever you see it. Because the world is traveling from invasive options to non-invasive ways of handling the situation is very important. Where we thought of some knife and something, this and all might work and all. We now say like about now, we talk about like non-invasive, something like maybe if medication can work. And many specialties, especially the special surgical specialties, might disappear and all those things. If somebody has a tumor, and if you're able to target the tumor with a nanoparticle, and if it can fire the particular tumor and the tumor disappears, and possibly some specialties might disappear and maybe some new specialties might come up, something like gene therapy and all those things. But speculative, but nothing is impossible. Nothing is impossible. So nobody expected man to fly in the sky like a bird. But it happened. It happened. It happened. And the first vaccine, it took 3,000 years. I repeat again, the first vaccine for smallpox took 3,000 years for Edward Jenner to prepare it. And next vaccine, that's my last vaccine, that's COVID vaccine, came less than a year. Now, what does it mean? Look at scientific advance. Yes, there might be debates about what is good, what's not good, and all those things. But attempt was there, deeds were there. The intent was clear. The intent was clear is most important. We should not forget. Intent was very clear to save the humanity. And this is one of the best times to live on this earth. No world war. What a pandemic you had, and you had some vaccines, some solutions, some medication. Yes, we lost some of our close relatives, friends, and maybe parents and all. But having said that, yes, why not? Why not? Let's fight it out. Challenges keep coming. Every challenge, opportunity to learn. So in this context, I would like to move on to next slide, madam, please. So the humanity kept on wondering how to solve the pain problem and all this. Not the pain came suddenly just like that. No, the first person to have a pain, who first, in fact, we say early first pain physician happens to be, as per the literature, whatever this thing, or not literature, as to like perception and all those things. The first man who was there born on earth, whatever time he was born, and all those things. So when for his livelihood he had to climb a tree or he had to hunt animal and all this, he got injured and all those things. So that particular thing, that injury, was the thing which made him to realize that. So sometimes he kept his finger in maybe in running water and all those things, so to feel better and all. Sometimes he used probably some leaf concoctions and all those things and all. But tell me, how many of you have not done? Have not done. I'm again repeating. Have not done. As a child, you put your finger. I think most 90% of us, we put a finger between the door and the wall, and the finger got injured, or something. We put some finger somewhere and got injured, and immediately we kept the finger in the mouth. Immediately we kept in mouth. The reason it happens because it's reflex. From where did it come reflex? That if you injure your hand, keep it in your mouth. That gives release. That's basically, that's nothing but pressure application. Now also, if you just see what we say is, in case you get injury, please apply strong pressure, because that numbs the pain receptors. So that's an innate immunity or innate thought, or you should say innate memory, which is there in our body. Something goes like this. For a small baby, who taught if you put your finger behind the door, put the finger in the mouth? Who taught them? So this innate memory which comes like a reflex. Forget about this. If you say that is something great about it, think about it. Who told the calf after the birth to look for mothers, the feeding area, the milk feeding area? And how did it recognize that milk come from there? What exactly? So this reflects what we have to understand. That's very important. And this particular thing is going from early man to the modern man. Still the debate goes on, and you have to see how it is going to happen over the course of time. And next slide, please. So this is one of the beautiful slide from, I think, for people who read maybe Robbins pathology, Vinay Kumar Robbins pathology, way back in 1987, 88, and all this. Some of my teachers might remember. So just look at the pain, what a stimulus you have on the skin over there, and if you just look at the first instance, what exactly happens. So you get the potassium gets released, prostaglandin, and hydrogen ions, and of course released. Then the blood vessel, bradykinin gets released. The image gets, impulse gets propagated. This is the primary activation. From the secondary, from the free nerve endings, it goes to release substance P, There's platelets and 5HT, touches mast cells, hydrogen ions, impulse get propagated. So that's how the acute pain model runs and all those things. But if you just look at postoperative pain conditions, don't forget about that one. So many of you might be a surgical legal faculty and also anesthesia faculty, or maybe a physician faculty also. Think about how many times you see patient in the postoperative condition suffering with pain in the best of the best centers in the world. Almost it is recorded again and again. It's recorded. Almost 60 to 70% people still suffer from postoperative pain in the postoperative pain after the surgery is over. The reason being, there are about 23 to 25 I repeat, 23 to 25 inflammatory mediators get released after the any kind of I should say injury. Injury means surgery is nothing but a planned injury. Planned injury means it could be for the intestine, could be for the skin and all those things. It's a planned injury. But stabbing is unplanned. That's a different story. But surgical thing is, but response will be by and large same. In that case, when I see 25 inflammatory mediators getting released, what are the analytics we have in our hand? Look at the challenge. So, for example, if you're talking all these things, we use the biggest thing. What's it? It's the prostaglandin secretors and all. So we got prostaglandin inhibitors like maybe diclofenac or aceclofenac or maybe ibuprofen or something like that. Maybe paracetamol you can put in the same group. And then you got some opioids which you can postoperative period. Nothing wrong about that one. Then might use something like local anesthetics, do nerve blocks or maybe local infiltration. That's fine. Then maybe acute pain, you must try steroids. May not help, but you can try it on all those things. Beyond this, about 5, the what else you have got? I say 25 mediators. Because there are interleukins which get released. We don't have anti-interleukins. Complement get released. We don't have anti-complement. Then so many things get released over there. Then what do we have in our hand? Why are you trying to say that like when the post of pain and all those things, you give 3-4 medication which is available in your hand, and then say beyond that, if patient says pain, you say is this psychological? Leave it there. That is not the way. That's not that's where we are suffering. Because in year 2004, in fact, a study came from one of the universities in the US, and in fact they said about that one. People different haplotypes and all that, like ALA kind of thing and all. Some of them have the transporters, some of them do not transporters. A simple thing, I'll tell you an example. If somebody, a surgical team, for example, does inguinal hernia on one side, right side, same anesthetic person, same spinal anesthesia, same probably the postal anesthetic diclofenac, gets good relief, but next patient, same surgeon, same side hernia, same anesthesia consultant, same medication, he won't get good relief. Now, what is the reason? So what was deduced in somewhere in 2004 was they said there are some phenotypes where some people, even if you get diclofenac, it might be circulating in the plasma because you need a transporter. People who have seen the movie Transporter probably they'll understand. Transporter takes the diclofenac to the receptor. If some of us you're not having the transporter, the transporter, probably the diclofenac may not reach the receptors. In that case, what happens? Diclofenac probably who had the first patient, second patient, serum will be the same. But at the end of the day, one had good relief, one didn't have good relief. So these are the ambiguity set of things we have to address. It's very important at this particular point of time. Next slide, madam. Next slide, please. Yeah, this is one of the beautiful work from one of our Indian Ramachandra Guha. If you just look at phantom limb pain, many of us would have heard about this particular thing. The limb doesn't exist, but patient says the limb is there, but pain is there. So that's what I'm trying to say. If you just look at the screen over there, on the right-hand side, if you can say right and left, it's written that this is cortical imaging because of the functional MRI. If you just look at the area, probably the lip and all those things, because this is called a sensory homunculus. Sensory homunculus, where we talk about sensory and motor cortex and all, where the body is put in an inverted position as such. If you just look at lip area is closely linked to the hand area. And probably, I'm sorry, I can't really handle the slide because I'm handicapped because somebody is trying to handle. And one thing is, if you just look at this particular sensory homunculus area, where probably this is there, where lip and probably the hand is coordinating, and if you do intense rehabilitation, the lip and hand gets separated because it's something a patient complains like whenever I'm chewing, the pain increases. You'll start wondering why should when somebody chewing pain, because The lip area has grown into the hand area. That's the whole idea here. Lip area has grown hand area. If you follow sensory homunculus, definitely you'll be able to understand this particular concept. Next slide, please. So these are the principles of pain management with acute pain or chronic pain. The first of all, must treat the underlying pathology. If there's it's a bone fracture, please fix the fracture as simple as increasing the pain tolerance threshold. Pharmacological approach. We normally use medication. Somebody comes to our emergency room with a fracture or maybe some acute pain. We use the medication so that at least the acute pain is under control. So before we can evaluate, and there can be non-pharmacological approach, but of course difficult in that kind of thing like meditation, hypnosis, and all. Difficult to implement, but not impossible. But somebody who takes it as a routine work, it's fine. Pain pathway inhibition modulation, the increasing endorphins opioids is something like acupuncture and all this, but I would not discuss because we're not supposed to practice particular thing. Stimulation of spinal cord gate is more towards, I would like to say, for the chronic pain patients, and of course, again, in different context. The last but not the least is the intravenous pathway, that's nerve blocks. That's the last thing, because a lot of time if you do nerve blocks and all those things, there could be difficult assessing the neurological damage if at all something has happened. So it always should be in concurrence with people. Next slide, please. So these are the pharmacological agents normally we use for pain management. At the periphery, which might work is maybe local infiltration, if again the topical anesthesia for the ocular surgery, or maybe infiltration, peripheral nerve blockade. Normally NSAIDs are the paracetamol or opioids, and the epidural local anesthetics for the blocked dorsal ganglion. At spinal cord level, again epidural intrathecal opioids, local anesthetics, which we use for the anesthetic purpose. And of course, the systemic opiates and psychological methods are being used for different contexts and all. Next slide, please. So interventional payment is something like, I should say, interventional cardiology or radiology, where we feel that at this stage, sometimes medications beyond the limit may not be offering much benefit. So in that case, the probably we'll have to do something better than what we had done. Next slide, please. Next slide.
Move the next slide, sir.
Yeah, next slide, please.
Interventional pain management.
No, next slide, next slide, next slide. I'm just going through a bit fast. I think you have no program, I can make out that one. When it comes to international pain management, the techniques, of course, many of you might have heard of. Intervention basically something is going on, you intervene and then try to stabilize the situation and all. We have non-imaging assisted interventions, fluoroscopy, assisted interventions like in GPRS and all. Then you got USG assisted interventions, CT guided. Depending on the technology available at the source center, it can vary from center to center, but that's fair. But these are things which are available. Apart from medications which we have been using for acute pain, like local anesthetic, NSAIDs, and opioids, or paracetamol, or steroids, and all. And for neuropathic pain medication, we use like antidepressants, like amitriptyline, nortriptyline, maybe anticonvulsant, pregabalin, gabapentin, and then some medication. Apart from that, we have some interventions which can help the people. But a lot of these things have been refined because the imaging assistance. In that context, probably I would like to mention a few of the things which have improved a lot. Next slide, madam. So non-imaging assisted interventions, as you can see, like those just probably for doing our portion, we used to do some of things because we didn't have the probably access to the some machine or from the fluoroscopy and all. And if you can just look at maybe used to look for corporation syndrome and all, and I think there is I think probably one this thing can be muted probably. I think some disturbance over there. So just look at the probably the corporation syndrome and all those things. We do certain injections with maybe local steroids and all. And if you just look at the same thing applies to the especially chronic post-surgical, if somebody undergoes lumpectomy or maybe hernia surgery, might end up with probably a scar, and probably that can be managed with maybe steroids. That's most important. That's the way we have to look at it. Next slide, please. The fluoroscope assisted interventions we keep using for quite often is more like GPRs, like you're more accurate, but very deposit medication, because a lot of things we have learned over years, like what works or what doesn't work, and why something is working or something is not working as such and all. And in that context, very important, because for SC joint pain, for the back pain, and for the post-epineuralgia or coccygenia, we have some answers at this stage. Next slide, please. And if you can just look at the screen, trigeminal radiofrequency ablation, if you just probably focus on the picture over there, probably if you can just see the lower picture on the left side, and as per the screen, and you can see the foramen oval there, and then the fluoroscopy, and probably here we always, previous slide, please, sorry. You can see the from medial to lateral. If you just see that's a way the nerve arranges, ophthalmic, maxillary, and mandible. So we had to understand how. So if you want to have only somebody's mandible division problem, you can go to the lateralmost part of the foramen oval, do only lesioning for the mandible division, so that he will not have to worry too much about the pain about that one. So that we don't have to spare sacrifice ophthalmic and maxillary division. So this how the imaging has helped a lot. Fluoroscopy is trying to see the foramen oval, where we are looking for anesthesia technique, alcohol, phenol. Now we are going towards radiofrequency ablation, those kind of things. Next slide, please. Now, this is for the epidural injections and all those things. Because normally what we keep on seeing is for the back pain, yes, there are some major conditions about where obvious disc prolapse, fracture, and all, where the surgical team would like to consider probably the surgical option for 10% of patients. But there are some conditions where probably we only physiotherapy and all. But in between 60-70% of patients, they have the pain, the disc is not big, the surgical team is not keen to operate. The physiotherapy people have tried their level best for 6 to 8 weeks or maybe 12 weeks. Still, people continue to complain of pain and all. There we think of epidural injections and all, where we are doing it blindly and all those things. Because sometimes what happens, the epidural space is not a single space like esophagus. It's like it evolves from both the side, right and left. So when you do it without imaging and all those things, you put a needle in the back and you start looking for loss of resistance standard technique. You might end up with the right side or left side. Basically, you might go to opposite side also if you're not sure about which side the tip has gone. So here, the fluoroscope imaging helps you a lot, and it can be side specific. That's right or left. You can see the contrast picture over there. Epidural space on right and left, you can see on the picture very clearly. Next slide, madam. The transfer arm, you're not only side specific. Say, for example, if the left side L45, then you can go for left side L45. Here you can see the route also, like one exiting route, one traversing route. So it's very quite clear as such and all those things. So we are not only side specific. There was one time they used to get a series of 3 injections. No, not really. You don't have to kill the snake again and again. The first shot itself, you're at the bank on the target, and you don't have to go for second injection. So that has been the way dictum what we have been doing, and not only here, across the world, that's a concept as such. You don't have to go for a series of 3 to 5 injections or 12 injections. No, not really, not necessarily. Next slide, please. So this is some of the similar chain blocks, because these days, as you see, people, I told in the initial part of my lecture, people live for longer period, and probably once you cross 40 years, you might be diabetic or maybe essential hypertension. Somebody puts you on probably the acetylsalicylic pill, and you'll be taking it, or maybe clopidogrel, something like that. And the difficulty comes that you stop for 5 days, 3 days, and all. And somebody has something kind of Berger's disease and all, you put him on clopidogrel, stop and all. You cut the back and to operate, do lumbar sympathetic difficult. So you can do CT guided, fluoroscopy guided lumbar sympathetic block, and probably the middle picture, it's a ganglion impart block. It's one of the youngest ganglion which was born actually in 1990 from discovered from Pancart. So that's a question that's very important, because both lumbar sympathetic chain, they come and meet in the middle, and that's how the ganglion of Walder, that's what it's called. That we use it for especially for perineal cancer. Perineal cancer, something like, say, I should say vulval cancer, prostate cancer, and all. And the superior hypogastric plexus block we use predominantly for the pelvic malignancies, and the lumbar symphysis we predominantly use for vascular disorders where small vessel disease is there, and celiac plexus block for the most often used for the like see a pancreas or see a stomach or something like that. More predominantly I should say like midgut malignancies we use the celiac plexus block, and hindgut malignancies is hypogastric. I think beyond that one, then we go for the hypogastric, or for that matter, go for the ganglion of Walther. Next slide, madam. Epiduroscopy. I think for all people who are seniors, they can understand at this particular point of time. There was one time probably a lot of GJ vagotomy used to happen earlier, and especially people who are the faculty professor who are about to retire and all. But we rarely hear GJ vagotomy now. Subsequently, once endoscopy can picture ultrasound, we realized many of the ulcers which were there in the stomach, they were amenable to the poly H2 blocker, like or maybe proton pump inhibitors, what we used, or maybe ultrasound should have maybe gallbladder stone. Now we see more of lap chole or something like that, but less of GJ vagotomy. So epiduroscopy is something like you put a scope in the back and check if something is there. But as of now, the technological point of view, we can only see probably the fat, lymphatics, and the blood vessel in the epidural space. And but beyond that, people have tried out like in hemostasis with respect to doing lesioning and all, but it's still it's actually like it's a story under construction. That's how I would like to take it at this stage. Next slide, please. Next slide. Yeah, I told about the CTG procedure for the malignancy and all those things. You can get a specific procedure block and all where patient cannot really might be palliative treatment and all those, because visceral block, sympathetic blocks, these things can give relief about 80-90%, because whatever morphine you might give, you can give 50-60%, because visceral pain is different, and the best thing it works with the celiac plexus block, and usually it gives relief for 8 to 9 months. But we do get some times so what's called a chronic pancreatitis, again a bit tough to manage as such. Next slide, please. Radiofrequency ablation is something like electrocautery, I would like to say. Electrocautery, you don't have control temperature. You use the probe and maybe you might char the tissue and all. Radiofrequency, like for example, many surgeries were done thinking that disc was the culprit, but subsequently found the disc was not the culprit. It's facet joints which are culprit and all those things, of course. Talking facet joints, it's not a scope of today's discussion. Radiofrequency ablation, local anesthesia, they do very well at this particular point, especially the old age people who have got a spine and all those, not keen to go for surgery, difficult to do surgery, not willing to understand the complications. These kind of things makes a lot of difference as such. Next slide, please. Next slide. Spinal cord stimulation is something like a pacemaker. Like a pacemaker regulates the heart. You got you put a lead inside the epidural space, and then it's time to say it came in somewhere 1960 and all. There's no structural damage. Just put a lead there, and it keeps on working as long as you want to work. For battery is the only limiting factor. These days they got can recharge the battery without any wire also, so you don't have to replace it also. You can just charge it from outside. One thing is it substitutes the pain with pleasant sensation. Somebody has like a 3 surgery spine or something like that, or will be radical symptom. You can put the lead over there and then stimulate, confirm, patient comfortable. He can switch on, switch off the mobile, like the pulse generator, the way he uses the mobile phone. Bit expensive those days we used to say, but now when people are going for 6 to 8 lakhs for a joint replacement, and if this is going to cost 6 to 7 lakhs, I think people are going to accept spinal cord stimulation coming years. Next slide, mate. Next slide, please. Intrathecal tubular system is predominantly used for like a spastic children and all those things, and also used for cancer patients where the lifespan is at least more than 3 months. So where we take morphine cause constipation, we put the pump, so that minimal amount of morphine might be required to deliver it in the CSF, so that patient is comfortable without much side effects. Next slide, please. There are advanced neurosurgical interventions like vertebroplasty, I don't call them advanced because they're available in India for more than now 3 decades. But you've got particularly cardotomy, deep brain stimulation, tractotomy, thermotomy. Very few centers in the world are doing, but they come with their own penalty with respect to the risk involved in handling. But there are experts who are doing it. We don't do it, but these are the things which are available. That's what for the benefit of the house I just wanted to share. Next slide, please. I think I'm coming to the end of my lecture. So the benefits of this IPM like interventional procedures are the non-analgesic benefits are limitation of side effects, improved quality of life, and of course the weight gain, because side effects with opioids, NSAIDs, and the gastric discomfort goes down. People are less sedated, they're active in their life, alert and satisfied patient. But a combination of medication and interventions are most important. Most important is like meaningful expectation of the patient, what exactly he expects at this stage. And imaging assistance offers safety and accuracy. Something like that is very important, the GPS kind of thing. Don't use the blind technique, please use imaging. It's available everywhere. Next slide, please. So a lot of things are being done in different organizations like World Federation, like Intensive Anaesthesiologists, and Traveling Pain School, International Study of Pain, ANSCA and all towards only one thing is to train people in handling the pain, because that's going to be the upcoming problem in coming years. Next slide. Patient comes with so much confidence to you. Please don't walk into the sea near Pondy with this kind of arrangement with respect to the bottles being there or their back and all. Please make sure patient is safe. You are also safe and patient is safe, so that that's the way we have to go about it, so that everybody is comfortable at the end of the day. Sarve jana sukhino bhavantu is what we keep on saying about that. Make sure that you take care of them. Next slide, please. To conclude, I would like to say pain is one of the most common reasons that people seek medical attention. Needs to be managed aggressively and systematically. Treat acute pain promptly and aggressively to possibly avoid chronic pain. Use combination of drugs to target multiple points of pain pathway. Multimodal management of pain can provide better efficacy with reduced side effects. Next slide, please. To conclude, I would like to say we started as probably the monkey or something like that, and then the early man, then we had a stone man, then iron man. We thought we got a good man, but we thought we got a better man, but unfortunately we ended up as a coke man. So let's make sure that we don't get into sedentary life. And a lot of innovations are happening. It's not the end of it. Probably what you can see like a bead of pulse. What you can see next to thank you. It's not bead of pulse. It's a medicated film, I would like to say, with the local anesthetics, opiates, NSAIDs, paracetamol, that is incorporated in the wound so the patient has good relief for about 2 to 3 weeks. With these words, I would like to say thank you once again. Sorry for all the inconvenience because of me. Thank you so much.
Thank you, Dr. Joshi, for that wonderful lecture. I'm very sorry for the technical things. I'm more responsible for all the confusion.
No. I'm also responsible. I had no difficulty.
Yeah, moving on to this thing. There was one thing which was very impressive was what you brought out, no? Sarva jano sukhino bhavantu. That is the most important message what we got. And if we really got, to quote that Neil Strauss, he keeps saying that people go through so much pain trying to avoid pain. And using multimodal approach and various non-invasive, like moving from invasive to non-invasive, like our friend Saurav Ganguly, who is now having the 5th stent inserted. Like that, I think that is what we are moving on to. So before we actually take the audience question, I just want one question, sir. Being anesthetist, I just wanted to ask you, can you a little bit elaborate about preemptive management of pain, sir? You spoke about multimodal.
Yeah, exactly. Actually, there are two things what we should understand: preemptive analgesia, preventive analgesia. I repeat again: preemptive analgesia, preventive analgesia. The preemptive analgesia we discussed, it was a big thing about 3 decades back, in the 1990s, and it's a big thing. The preemptive analgesia, like if you load the person with morphine beforehand, he'll not feel much pain post-op. But somehow it did not yield the desirable results and all. Now, what we're talking is preventive analgesia, because the surgical load is slowly increasing over the last 3 decades. Many conditions where we didn't have answer, we were trying to manage medication and all. Now we are able to get a lot of surgical intervention. So, as part of preventive analgesia, what we are trying to achieve is use solid analgesia on the table for pre-op on the table, and also post-op also, maybe with some kind of a nerve block or something like that. If the memory of the particular, because it takes 48 hours for the person to feel comfortable and all those 48 hours, if you can put good analgesia, the bombardment won't happen to spinal cord or the sensory cortex, and maybe that is one way to reduce probably the incidence of chronic post-surgical pain. This hypothesis, it's not proven, but it's hypothesis. But you don't know. But the preventive analgesia these days we don't practice. But definitely preventive analgesia is very important. Very important.
Thank you very much, sir.
Yes, madam.
The other thing which is very striking about pain is the cancer pain, right? Sometimes some of the patients have described, so the pain strikes them like a lightning suddenly from somewhere, and it is so constantly present. That the two concept of neuropathic pain and nociceptive pain. So can you please go a little further on that?
In fact, when we see patient pain, there's two things: nociceptive pain, neuropathic pain. Neuropathic pain, it starts firing on its own, it stops in its own, starts firing, stops on its own. But nociceptive pain usually gets triggered only when you're active. You walk, pain comes. You lie down, pain goes off. So this is how the subtle thing we keep, because people come for fellowship program and all. We always say subtly, because medications and plan are totally different. Neuropathic pain, you're lying down, if you start firing, no activity but starts firing, that means more neuropathy. The nerve is firing on its own. But nociceptive pain, it's not like that. If you're not active, it might be just quiet. Like it's simply a vertebral body fracture. You're lying down on the bed with a fracture, nothing. If you take a turn, the pain comes. Because management is totally different, so that it should be. But there could be a combination of both. Nociceptive neuropathic. Osteoarthritis pain, somebody who's diabetic also has got neuropathic pain. So it could be combination, with one of them being predominant, neuropathic predominant and nociceptive predominant. So as you keep on working on that, you start realizing what is good or what is not good, what's appropriate, what's not appropriate. You can always learn these things for trial and error method wherever you are.
Yeah, thank you, sir. I think that was the question we had from one of the participants who had registered for this. Before we move, I would like to ask Dr. Kutur to say a few words, and maybe he has a question for you, sir. Over to you.
He's my teacher only. If I can't answer, he has to answer.
Thank you, Murali. No, other than thanking you wholeheartedly on behalf of our institution.
Thanks for the opportunity, sir.
Yeah.
Yes, sir.
And one thing is, I can say at this point of time, you are the one who has been streamlining the specialty of pain, in various platforms.
So learn from all of you, sir.
And motivate anesthesiologists to take up the pain management. And I already said that my 3 or 4 of my students you are grooming them as pain therapists.
Sir, one of them got a fellowship in Canada today, sir.
Oh, excellent! Who is that?
Amar Reddy.
Oh, great! So nice.
He got fellowship today.
So the credit goes to the teacher, no?
No, sir. You are the teacher for him.
Okay. Anyway, that's a good thing. And I already said that when this the COVID is normal situation is totally restored, for your very favorite pain hands-on training workshop for these undergraduates.
Sir.
Okay, so I will be looking forward to have that.
We can definitely plan, sir. That's still popular, is going on, sir. Probably once the COVID settles down, for undergraduates, definitely we can do essentially pain management with the collaboration with the ANJCA, the National New Zealand College of Anaesthetists. The program is very much on, sir. We can definitely have it, sir, whenever you want.
Thank you. Thank you both.
Thank you, Dr. Murali. Thank you for that wonderful lecture. And I hope that the audience they stayed from the beginning to end. That shows that how impressive this lecture was. So I thank you wholeheartedly on behalf of the Scientific Society of AVMC and also the AVMC institution per se and VMRF, our parent university. Thank you very much for this wonderful lecture. We have some announcements for the audience. The first and foremost is you will be getting your feedback links today. So once you finish the link, you will be getting your e-certificates. You can download them. We will also be sharing with you the recording of this talk so that you can go through it at your own leisure. So please don't forget to visit our YouTube channel. And also, we will be stopping this cancer cure, that is series 7 with this episode. From next month onwards, we'll be moving on to the next series, that is series 8. And series 8 is going to be on emerging and re-emerging infections. So we have with us none other than maybe Dr. Muralidhar Joshi also knows. We have Dr. Ranganathan Iyer, who is with the Indian Association of Medical Microbiologists Society. And he is a clinical microbiologist. Actually, he is one of the unique distinctions in the country being a clinical microbiologist. He will be talking about what is new about hospital-acquired infections in the current COVID scenario. So that's the talk for you next Friday. That is on 5th of February, afternoon 2:45 p.m. Till then, stay tuned, stay safe. And as Modi ji says, vaccine is safe. Probably that is the time for AVMC to take vaccines. Please go do that. Thank you very much. See you next week. Bye-bye, friends. Thank you, sir.
Thank you so much. Thanks a lot. Jai Hind.
Jai Hind, sir.